Hi, good afternoon, and thanks for paying attention to our video broadcast from the Palm Beach County Medical Society. So again, I'm Dr. Larry Bush, president of the Society and an infectious disease specialist. So there's been a lot in the news lately, both in the media, electronic, and in the paper about testing, the significance of testing for COVID, what it means, and now obviously about possibly having an antibody test, and also about the use of what's called convalescent plasma. In other words, a blood product obtained from a person who recovered from COVID and possibly giving to somebody who's actively infected and doing poorly, and maybe having that help them to a great degree. So I thought we would talk about that for a few minutes. But before that, if you would, allow me, I wanted to talk about just a little bit of infectious diseases. And I know for most of you, this is just a rehash. But let's just talk about what infection means. Infection just means that an organism is living on us or in us. It doesn't necessarily mean that organism is doing any harm, because in essence, we're all infected. Our skin, our nose, our intestines are colonized. In other words, bacteria live there, and for many times for good purposes. An active infectious disease is when one of those bacteria or viruses, or what we could say a parasite or a fungus, harms our body. And when it harms our body, there's a reaction. And that reaction is what we define as active infection, usually defined as having signs or symptoms, things like fever or pain or redness or swelling or cough, etc. Now, when organisms cause infection, active infection, they do it in one of two ways. Either they produce a substance that directly harms our body, such as a toxin. An example would be, let's take the classic, botulism. Botulism isn't so much the bacteria, it's the toxin the bacteria makes that we eat, which harms our nervous system. The same thing can be said for tetanus. The same thing that can be said for Clostridium difficile. It's the toxin. And of course, anthrax is a toxin too. It causes a lot of damage inside the middle of our chest. So that's a direct harm to the body from a product of the organism called a toxin. The second way the body reacts to an infection, an active infection, is local inflammation or systemic inflammation. So for instance, if a staphylococcal bacteria invades our skin, we may get a boil or a furuncle, and that's pus. And the pus is your body's inflammatory reaction to fight the infection, because that's been built into our body forever, way before there were any antibiotics. The second thing that could happen is that this inflammation could be systemic. And when it's systemic, our body produces chemicals. You've heard of the cytokine storm, things like interleukins, other chemicals. Those chemicals help recruit things that help fight the infection. But unfortunately, sometimes collateral damage happens. Your kidneys, your lungs, your heart, other parts of your body get damaged by the fight against the infection. We become the collateral damage. And normally, our body's able to counteract that by anti-inflammatory mechanisms. When the inflammation overcomes the anti-inflammatory mechanisms, people are defined as what is called septic, and is organ damage. So that's infection. So having an organism doesn't necessarily mean it's causing you any damage. That's infection versus active infection, which brings us to testing. As you know, when we test for an infection, there's three ways. You can directly isolate the organism. The classic is you swab somebody's throat, they have group A strep, and it grows on a plate, a culture plate. Or you culture their urine, it has E. coli, and it grows on a plate. You've identified the organism by culture. We don't do that for viruses in a clinical lab. That would require a research lab, because you can't grow the viruses on routine culture. It's much more sophisticated. So then we looked at defining an infection by other ways. One is by PCR. PCR stands for polymerase chain reaction. And what you're doing is you're amplifying the nucleic acid of the organism, either DNA or RNA. COVID is an RNA virus. So when you swab the back of somebody's throat, or you swab their nasopharynx looking for the RNA, it's a PCR, a polymerase chain reaction, looking to react with that RNA. But here's the question. The fact that you can find it doesn't necessarily mean there's active infection. It just means that there's COVID virus sitting in that part of their airway. Those are the asymptomatic people. They have no signs or symptoms of active infection, but they do have PCR. The question is, are they going to develop signs or symptoms of active infection? Some of them will, some of them won't. We only know the ones who do because they have signs or symptoms. The other issue is, can they spread the virus? Well, obviously, the virus is sitting at least in their nasopharyngeal cavity or in the back of their throat, and if they have saliva or cough or sneeze or secretions, they could spread it to other people or the surface. But the other thing to keep in mind is sometimes with certain infections, it depends on how many organisms are actually there. An example, salmonella food poisoning. You need to swallow a lot of salmonella versus Shigella food poisoning. You don't need to swallow that many. So how many of the COVID viruses in the nasopharyngeal area really do you need to develop active infection? When we're doing a PCR test, we're not saying how much is there. It's not like doing an HIV viral load. You don't have a count. All you know is it's there or not there. That's that. Number two is once somebody has had active infection and they've overcome it and they're better, and we say, well, let's swab them again to see if they still have it. The fact that you can still isolate it in their back of their nasopharynx doesn't necessarily mean that those organisms are very viable and can cause active infection again in them or somebody else. Is it transmissible? I think you would have to assume they are. So follow-up swabbing to see if somebody's better, that's a clinical decision. Following up swabbing to see if somebody still has the organism doesn't necessarily tell you how contagious they would be or if they're very contagious at all. It's just information that's a little bit hard to put into context. Which brings us to what we're hearing about now, antibody testing. Antibody testing is an indirect way of defining an infection because you're not actually finding a part of the organism. You're not actually cultivating the organism. You're looking for our body's response to having been exposed to that organism, a bacteria, a virus, a fungus, etc. When you do that, the antibodies may only indicate that yes, they've been recently infected or yes, they've been infected in the past. And therefore, we look for two types of antibodies. The first one that comes up is called IgM. It usually lasts for a few months, and it would imply that there was recent infection, either with symptoms or without symptoms. The second one is called IgG, and that usually means that it's been a little longer since the patient's been infected, and it may mean they have immunity. But here's the problem. The concept that I seem to be hearing all over the media is that if we test people and we find that they have IgG antibodies, A, they're immune, and B, they're no longer contagious. Well, that's not necessarily true. There are many infections where you can still shed the organism although you have antibodies, because the antibodies may not have totally eliminated the organism. That's number one. Number two, just because you do have those antibodies doesn't mean that you are totally immune from that, because there's lots of diseases, particularly viruses, where we have antibodies to the virus and you still have active infection. An example is HIV. Another example is Epstein-Barr virus. Another example could be things like influenza, etc. So just because you have antibodies doesn't necessarily mean you're immune, and you can still shed it because antibodies are just one part of the immune system. And it could be that for fighting COVID-19, there's other parts of your immune system that are just as important, which are ones that we don't easily measure. Which brings us to the third point I wanted to mention, convalescence serum. Well, when you're getting convalescence serum, what that means is you've taken a patient who's had proven COVID-19, they've convalesced, meaning they're clinically better, and now you test their blood and they have IgG antibodies. And the concept is if you harvest their blood and you give those antibodies to an ill person, that those antibodies may fight the virus in that person and help them get better. Well, that's true, but as I just said, they may have other parts of the immune system that are just as important or more important in fighting the COVID virus. Number two, we don't really know how many antibodies somebody has when we test positive for IgG. So when you take their blood, they may have very few antibodies, although they're there, whereas the other person has a lot of antibodies. In other words, when the one blood, who is the blood group in Palm Beach County, who harvests the IgG antibodies and get them in a form that they could deliver to another person, it doesn't mean that this person's and that person is given the same amount of antibodies. When we give immune globulin for diseases like hepatitis B or hepatitis A, that's been quantified. And we're not giving them plasma. We're giving them purified immune globulin. That's made in a commercial lab. That's not what's going on here. Number two, when we give people plasma with IgG antibodies from a convalescent patient, that plasma has to match the donor, and the recipient have to match just like a blood donor would be, because they can have a bad reaction to the plasma because of mismatching, just like it would be with a blood transfusion where there was a mismatch. So yes, convalescent IgG plasma sounds very good. It was tried in Ebola. It seemed to have some success, but it's certainly not the end all, because I hear, well, convalescent plasma was given and the patient didn't do well. And again, there's a multitude of reasons for that. So yes, testing's important. Knowing who's infected, who wasn't infected epidemiologically is important. It helps you plan, it helps you use your resources, but it doesn't give you the silver bullet that we're necessarily looking for. What we're looking for here is an antiviral medication that works. We're looking for stopping the transmissibility of the virus by keeping people who are infected away from other people. And eventually, we're looking for a vaccine. But keep in mind, the vaccine that will be created will be specifically for COVID-19, this specific coronavirus. Doesn't mean it would work for any other coronavirus, which is likely to happen again in the future, because that's the world's experiment since the beginning of time. That's why we get a different flu vaccine every year, because there's different strains of flu. So these are all great ideas. Hopefully they're going to pan out. But the thing that is going to stop this pandemic is common sense. The same thing that stopped the pandemic in 1918 from the Spanish flu, from the greatest devastation pandemic that's ever hit. The thing that stopped it was people saying, this person looks sick, I better stay away from them. They didn't have any PCRs, they didn't have any blood tests, they didn't have any electronic media to create information that may or may not be accurate. I hope that's helpful. Tried to stay simple, and I know for a lot of people this is oversimplifying. I'm sorry, I didn't mean to insult you. Stay healthy, do the right thing, and we'll get past this. Thank you.